So the first specimen is a ascites specimen. So at low power, we see some like very big cells with high-grade atypia. So on higher power, you can see there is a cluster of cells, some with a very abundant but foamy cytoplasm. The nuclear show marked atypia, irregular nuclear membrane, prominent nucleoli. There's a smaller cluster of these tight, like tubular, three-dimensional structure with much smaller nuclear, but again with bubbly cytoplasm and perhaps some mucin inside it. So the patient do have the history of pancreatic cancer. So you can see these well differentiated and more poorly differentiated components together within this metastatic ascites specimen. So again, a different patient, ascites, history of pancreatic cancer. So in this specimen, most of the cells show single cell, but when you go to the high power, you can definitely appreciate that these are malignant cells. Comparing to the adjacent lymphocyte, it shows like markedly enlarged the size of the nucleus and prominent nucleoli. The nuclear shape is also irregular and not rounded. So this is already developed the poorly differentiated like single cell pattern inside these ascites specimen. And this is from the same patient. Yeah, from the same patient, separate specimen. And this one show more tumor cell and some arranged in a tight cluster, but majority of them show single cell pattern. So it's indeed getting more and more common. I think last year we don't have that many pancreatic cancer metastatic specimen, but this year it's getting really, really common. The next specimen is a sputum. It is coming from Yuanshan, our branch hospital. So majority of the sputum specimen in our hospital was examined at the chest department, not here in our pathology department. So we rarely will receive positive like sputum specimen. For these specimen, in between these squamous cells are coming from the saliva in the oral cavity. So these are contamination. These are not coming from the respiratory tract, from the bronchus, from the sputum. So it's very common to see saliva contamination. But here we do see a tight cluster of relatively like a foamy cell with some like intracytoplasmic like material. So it looks like a histiocyte. So we do have some histiocyte, which means that it has sampled the component coming from the alveolar spaces. So here we see a very tight cluster and with cohesiveness. So this looks more like epithelial cells and with a little bit of atypia. So again, there's another tight cluster developing three-dimensional architecture with nuclear atypia and small but distinct nucleolus, some bubbling of the cytoplasm. So these looks suspicious for adenocarcinoma, But because of the scant cellularity, scant lesional cells, we call these suspicious. There were some cells, I think this is mostly histiocyte, but the other cluster with these vacuolated cytoplasm, this is suspicious for adenocarcinoma. So we call this mutant suspicious. So the next specimen is from the Pura. The patient had the history of lung cancer, so that this is relatively easy. We have like a large cluster of very atypical cell. You go to more flat area and you see gigantic nucleus and the nucleoli. So this is relatively easy and quite common for us to see the recurrence of the lung adenocarcinoma in the Pura effusion specimen. So the next specimen, the patient had a history of pancreatic cancer. This is ascites. This is a relatively bloody ascites specimen. We have a lot of single cells, some with nuclear atypia. But I think it is quite difficult to determine if it's only histiocyte or there are some cancer cell inside. Perhaps these could be a cancer cell because these show a tight cluster. Again, this is probably a cancer cell cluster, but because the background hemorrhage and a lot of reactive change, I think it's better that we can do a MOC31 on these specimens. So this is cell block from the same patient. We do see a few cluster. One of these here, one of these is perhaps these two adenocarcinoma. The patient has no pathology specimen or report in our hospital, so I think it's quite important that we to be definite with the immunohistochemistry. So we will do a MOC31 on this specimen to confirm that it is a metastatic carcinoma in the ascites. So again, this is a Pura effusion. So you see these, you know this is most likely primary lung cancer. So indeed, the patient has history of primary lung adenocarcinoma. So this is compatible with the history. Let's move to pancreas EUS guided biopsy. So in these liquid-based cytology specimen, the cellularity is very low. However, in between we see scan, like atypical cells, and with definite nuclear atypia. And this tight cluster, I think this qualify a malignant diagnosis because first of all, it is very tight and you see variation of the size of the nuclear. So this is positive for adenocarcinoma. Next to it, there's a very bizarre cell, so this is also malignant. So even though we have very scant cellularity, it is okay for us to have a definite diagnosis. So next, this is a different patient. Again, it is pancreas EUS aspiration. So we have more tumor cell in these specimen. So this is a glandular aggregates with polymorphism of the cells. So this is positive for adenocarcinoma. In pancreas aspiration, it is very common to see benign component right next to malignant component. So this is benign ductal cells or intestinal mucosa, benign. So we have a lot of benign cells. In the background, we do have some necrotic debris. So this honeycomb arrangement, this is benign, but this is adenocarcinoma. So you can see the nucleus, and this is tumor necrosis. So you really need to screen to identify all the components. So again, the upper fragment, honeycombing, benign arrangement, this is benign. The lower, this is adenocarcinoma. So this is positive for adenocarcinoma. So another pancreas EUS guided biopsy. So on low power, this is benign. So we have a lot of benign elements over here with nice regular honeycombing arrangement. And we start to see some very tight, atypical, hyperchromatic element. And for these cluster, you can see that there is a abrupt mucin production over here. The cellular arrangement is very irregular. The long axis is crossing with each other, and the cellular polymorphism is striking. So this is adenocarcinoma. So you need to pick up the right cells to be definite to call it adenocarcinoma. The next specimen is also a pancreas EUS biopsy. This is a little bit more difficult. So I will suppose that for the biopsy, the tumor morphology can be intestinal type. So in this specimen, we only see this very tight, like tall columnar stratification epithelium. This type of epithelium is not innate in the normal pancreas specimen, normal pancreas tissue. You won't see this intestinal type of glandular cell. So this is most likely neoplastic. I think the best that we can tell is that we do see like epithelium suspicious for intestinal type dysplastic gland, but it is a little bit difficult for us to definitely call it adenocarcinoma just based on these cytology preparation. So we have some stroma here. Again, right next to it, we have this intestinal type epithelium with very tight and hyperchromatic nuclear, but the nuclear polymorphism is not evident. We do have very scant necrotic component here, so it's likely already invasive. But just only based on these cytology preparation, I think the best we can say is suspicious for adenocarcinoma. I think you have to see invasion in the tissue to be definite call. But we know this is most likely a high-grade dysplasia, and with invasion, because we already see a little bit of necrotic material in the background. So this is called suspicious. So it is important that we recognize what are the normal tissue or cell component in the pancreas. So in this specimen, we do see sheets of relatively bland-looking cells, but without a definite arrangement such as acinar or ductal or intestinal mucosa type of. We only see like these very uniform, regular, and small cellular component. You wouldn't think this is a flank malignant tumor. So when you see something like this, you need to think about what are the other tumor that can occur in the pancreas. So this is most likely a neuroendocrine tumor. So neuroendocrine tumor now is universal malignant in the pancreas, despite it is grade 1 or grade 2, it is still malignant. So we have these very uniform nucleus, with finely granular chromatin pattern. So I think this is a neuroendocrine tumor. The other differential diagnosis would be solid-pseudo-papillary neoplasm, as well as if you see more prominent nucleolus, it would raise the possibility of acinar cell carcinoma. So I think this is a neuroendocrine tumor, and indeed the biopsy, they already stand for neuroendocrine markers, so we can wait. And I think we should still call these my old like a routine reporting style for this is called atypical, and presence of a typical cell and cytomorphology compatible with neuroendocrine tumor, but we can also call it positive because it's a malignant diagnosis now. So let's move to a bone aspiration. So in bone aspiration, supposedly we will only see bone marrow element. So here we see like a very ugly malignant cluster, and it looks like adenocarcinoma. So it is a metastatic adenocarcinoma. The patient had a non-history of lung cancer. So this is compatible with metastatic lung cancer. The next specimen is thyroid aspiration. So in this direct smear, in the background we didn't see colloid. We only see some blood clots and quite some epithelial cells. When we go on higher power, this epithelial cell looks elongated with irregular nuclear membrane and occasional nuclear groove. So it raises the suspicion for papillary thyroid carcinoma. So if we suspect it is a papillary thyroid carcinoma, if we look carefully, we can find there's a pseudo inclusion over here, another one over here. So we would be very confident that we can call the TBS6 and the PTC. So this is a specimen of PTC. In the liquid base slice, the tumor cells are very scant. So it's only appear in the direct smear. So that is the case, all the case for today. Thank you. 等一下，45分的时候我们要。